Hi, my name is Christopher Sweeney. I'm a medical oncologist at Dana-Farber Cancer Institute and also a member of the ANZUP organization that led the ENZAMET trial. So the hypothesis was greater androgen receptor inhibition with testosterone suppression and possibly docetaxel would improve overall survival. So we've got a very unique patient mix of patients with high and low volume and some who did and some who did not get docetaxel. What we know is that for the overall study population, we clearly show a major improvement in the time to progression, both by rising PSA as well as measuring just the time to radiographic or clinical deterioration, symptoms, for example, emerging. We also note that there's a major improvement in overall survival. There's a 33% decreased rate of death. When we look into the data a little bit more carefully, the treatment effect is far more prominent in patients who did not get docetaxel in terms of overall survival. So the hazard ratio is much more impressive in those patients. We start to see only a hazard ratio of 0.9 in patients who had prior docetaxel. So we're going to have to pass that out, so the treatment effect looks less when enzalutamide is added to docetaxel. But yes, there is a clear improvement in the time to clinical progression if they got enzalutamide with docetaxel, but we need to work out, is that associated with a better quality of life and does a longer time to deterioration in clinical outlook? And also, with longer follow-up, is there an overall survival beyond the 3-year mark? The study was positive at the interim analysis, and so the data reports really on those who had the poorest prognosis, and the study treatment shows that we really do benefit those with the poorest prognosis early. We also note, unlike docetaxel, we have a clear survival signal in patients with low volume disease. Namely, we're seeing their survival rate go from about 80% to 90% at 3 years, which we haven't seen with docetaxel. We're waiting the long-term follow-up of the STAMPEDE study where they have more patients and looking at docetaxel in the low volume. We didn't see any real treatment effect with docetaxel in the low volume patients with or without the enzalutamide in this study, although it wasn't designed, but there was no hint that they were benefiting. But there's a strong hint that patients who got docetaxel with high volume, which was about about 2/3 of the patient, what we can definitely see is that the control arm with high volume, with docetaxel and just the standard non-steroidal, and to be clear, this study differed because we had a non-steroidal in the control arm, be it bicalutamide, flutamide, or nalutamide, which the other studies have not had. And what we can see is that the median survival with those who got docetaxel in the high volume resulted in the 3-year survival looking better, going from about 50% to about 65%. So this study differs from the TITAN study by having the concurrent docetaxel. It differs by having a greater patient mix with more patients with low volume, whereas it was predominantly high volume in the TITAN study, and a very low use of docetaxel, and it was only given prior to enrollment in the TITAN study. And similarly, the ARCHER study, which is enzalutamide in the same space, which also gave docetaxel prior to enrollment, and it was a limited number of patients who got prior docetaxel, and it was also only looking at radiographic progression-free survival yet. So I'm very proud to represent the ENZAMET team and have a much more granular study with multiple subgroups that have biological and treatment implications of how patients who present to doctors in 2019 of whether they should get testosterone suppression with docetaxel, with or without enzalutamide, or testosterone suppression with enzalutamide based on their chemo fitness and their prognosis, their volume of disease. And here I'd like to turn it over to Professor Ian Davis, who is the chairman of ANZUP, to describe ANZUP and this new collaboration that we've pulled together from around the world.
My name's Ian Davis. I'm a medical oncologist from Melbourne, Australia, from Monash University and Eastern Health, and I'm the chair of ANZUP Cancer Trials Group. ANZUP is the Australian and New Zealand Urogenital and Prostate Cancer Trials Group. We're a cooperative cancer clinical trials group covering all types of genitourinary cancer. We've got over 1,500 members across Australia, New Zealand and internationally, representing all of the disciplines involved in the care of these cancers and research into these cancers. ANZUP is the lead organisation internationally in partnership with other coordinating groups, including the Canadian Cancer Trials Group and Cancer Trials Ireland, which coordinated this study in Ireland and the United Kingdom, and also with Dana-Farber Cancer Institute. One of the great outcomes from the ENZAMET project is not only the results of the study, which we hope will make a difference for men affected by prostate cancer, but we now have an international global collaboration of cooperative groups, all with the same objective, to try to improve outcomes for people affected by genitourinary cancers. So there's a number of ongoing trials, again under ANZUP leadership, or where ANZUP is a major collaborator. The ENZA-RAD trial, looking at the role of radiation therapy and enzalutamide in high-risk locally advanced prostate cancer, and a number of other initiatives in prostate cancer and other genitourinary cancers.